right. Good evening, everyone, and welcome. My name is Dr. Sara Arian. I'm a double board certified physician in OBGYN and reproductive endocrinology and infertility at Boston IVF. And this week is the National Infertility Awareness Week. And in honor of this important week, we are having this live webinar for you to be able to ask your fertility questions. We aim to raise awareness about infertility and empower individuals facing these challenges. And our goal is to also promote advocacy and education regarding reproductive health and reproductive rights. Infertility is a disease that's unfortunately common, and it affects approximately 1 in 6 individuals who will, at some point in their life, experience infertility. And this is not including the LGBTQ plus couples and individuals choosing to parent without a partner who may also need assisted reproductive medical treatments, such as IVF, to be able to conceive and start and grow their families. When we talk about causes of infertility, on average, about 1/3 of the causes and etiologies are female related. About 1/3 are related to male factors, and 1/3 are oftentimes of unknown causes or etiology, or sometimes a combination, a multifactorial combination of many different causes. Now, without further ado, let's get started with your questions and delve into answers to some of your most commonly asked questions on this topic. All right, so first question that I got is assisted hatching a must for a frozen transfer, and what are the best, what are the benefits or the disadvantages of this? There's a layer surrounding the oocyte, the embryo, and and the oocyte, and that is the zona pellucida. And as part of the process of the growth and development of embryos, an embryo needs to shell out of this layer basically in order to be able to hatch and to attach to the endometrium, to the lining of the uterus for implantation. So hatching is, a natural process, part of embryonic development that's required prior to successful implantation. And oftentimes, if an embryo throughout its development is not meeting that developmental stage and not able to hatch naturally, we can interfere by performing assisted hatching as an extra step. And in general, there are no disadvantages. There's no harm in performing assisted hatching in the lab. And there are some studies, some mixed studies that show benefit to performing assisted hatching in order to improve implantation of an embryo. However, the data is very mixed and not very conclusive. And so, just like I said, based on some evidence, assisted hatching has been shown to help. So next question, how to go full term with pregnancy after having a miscarriage? So if I'm understanding this question correctly, how to be able to carry a pregnancy successfully to term after having had a miscarriage. So typically, miscarriages are common, unfortunately. So early pregnancy loss and miscarriages are pretty common, more common that we oftentimes talk about. 1 out of 4 or 25% of clinical pregnancies can unfortunately result in a miscarriage. Typically, when an individual has experienced 2 or more than 2 miscarriages, and they don't necessarily have to be consecutive miscarriages, this is what we call, by criteria, recurrent pregnancy loss, or RPL. And in these situations, for these individuals who have already experienced 2 or more than 2 losses, it is important to see a reproductive endocrinology and fertility specialist and to have a full RPL or recurrent pregnancy loss panel and workup done. So it's important to check for any chromosomal abnormalities or structural chromosomal abnormalities, including chromosomal translocations. It is important to check for autoimmune related causes for miscarriages, including antiphospholipid antibody syndrome. It is important to undergo a comprehensive, complete structural anatomical evaluation of the cavity of the uterus as well as the fallopian tubes. And depending on what are some of the underlying causes for having recurrent miscarriages and losses, we have different treatment options and different strategies on how to possibly minimize the risk for having a future loss of future miscarriage and improve the chances, the likelihood for being able to carry a healthy pregnancy. So it all really depends on the underlying etiology and the cause for the miscarriages and the recurrent pregnancy loss. Next question. If I started getting my period at 10 years old and I am now 32, does my fertility window end much earlier than someone who started their cycle later than I did? I am trying to determine if I should consider freezing my eggs at this time. That's a great question. Starting period at a younger age and earlier menarche by itself does not necessarily put you at increased risk for losing your eggs or onsets of early premature menopause. Um, the way female physiology and biology works is that we are born with all of our eggs. So we are born with all of our eggs at the time of our birth, and we are never capable of creating or making new eggs. And as we go through life and puberty, and as years pass, every month we are losing eggs. So every month women are losing on average about thousands of eggs, and you keep losing eggs until you are completely out of eggs, and that's when you will reach menopause. And so, based on this reproductive biology, physiology, it is very important to discuss options for fertility preservation, including egg freezing or oocyte preservation, with all young women, females, who are interested in preserving their fertility but not quite ready or not actively trying to conceive. And this is regardless of the age at which you started having cycles and having periods. It is fertility preservation, egg freezing. It is an important investment in your future fertility, and it's something that you should consider if you are in your 30s, and or if you are in general a woman who is interested in having your own biological child at some point in your life, but not quite ready to conceive. So it's definitely something that I would highly recommend for you at your age of 32. Most studies data show that the younger you are and the earlier you complete an egg freezing cycle, typically ideally less than 35 years of age, the chances of success are going to be higher and you will end up with higher quality, better quality eggs because as a result of aging, there's not only decline and significant decrease in our egg numbers and egg quantity and our AMH or anti-Müllerian hormone, but there's also significant decline in the quality of your eggs. And so it's something that I would highly consider, not necessarily because of your younger age of menarche at your age of 10 years of age when you ended up starting your periods. So hope this was helpful. The next question, I know the minimum uterus lining for a frozen transfer is 7 millimeters, but is 7 millimeters actually enough? Is this likelihood of a successful transfer higher with a thicker lining? The answer is no. Actually, there have been some studies and some data looking at different lining thicknesses, and this is very much individualized. And we came up with this number. Most studies have reported this 7 millimeter thickness, but it's not only the thickness of the lining, but it's also the pattern of the development of the lining. We usually try to look for a nice multi-layer trilaminar pattern as this lining is developing and growing and preparing for implantation of an embryo. And in answer to your question, it is not necessarily that having a thicker lining is going to be associated with higher likelihood for success. There are different studies that have looked at this, and there's no such thing as, necessarily having a thicker lining is going to be better. So in general, we want a certain thickness, again, individualized based, because what could be a thick lining determined as a thick lining for an individual could be 7 or 8 millimeters as opposed to 5 or 6 millimeters for another individual, depending on their underlying conditions. And then we are also looking at that nice trilaminar multi-layer pattern of the lining. Would you recommend someone under 35 do the assisted hatching you talked about, or move forward with a cycle without it, since it's usually an out-of-pocket cost? Yes, I do agree with you. Thank you for this question again. I think if you haven't had any previous failed IVF cycles, any major issues with embryonic growth and development, you might not necessarily need to have assisted hatching done as an extra add-on and have to pay the extra cost for it. And I would just proceed with IVF as normal without it. A great general question. What is the difference between IUI and IVF? So let's talk about this a little. IVF stands for in vitro fertilization. This is our most advanced technology, and basically this is one of our most advanced fertility treatment options. With IVF or in vitro fertilization, the goal is to stimulate the ovaries in order to grow and grow follicles and make the egg within the follicle grow and become mature, followed by extraction of the eggs from the ovaries, a procedure also known as egg retrieval. And then by obtaining sperm from a sperm source, the eggs and the sperm will be mixed and combined in the lab. So we will fertilize and inseminate the eggs in the lab with the sperm to create embryos. And once the embryos have been created, we can then proceed with preparing the uterus to put back an embryo, typically one embryo at a time, in order to help the individual conceive. So this is IVF or in vitro fertilization, which thanks to the advances in our technology, our likelihood of success with IVF these days is pretty high and can be as high as 60 to 62%, depending on the age of the individuals. IUI stands for intrauterine insemination or artificial insemination. This is a more simple, more basic type of fertility treatment option in which we will monitor growth of an ovarian follicle. Sometimes this could be a natural cycle IUI without using any additional medication. Sometimes it could be a medicated IUI cycle where we would be using oral ovulation induction by having you take an oral fertility medication or pill, monitoring the growth of the follicle and the timing of ovulation, followed by directly injecting or inserting the sperm inside of the uterus directly into the uterus at the right time of your ovulation. This is an easy, quick procedure that's done within a few minutes. It's pretty much like having a vaginal pelvic exam done. Using a very small catheter, the sperm will be placed or injected directly inside of the uterus. The likelihood of success with an IUI procedure is not going to be as high as with IVF, and oftentimes lower, about 3 to 4 times lower compared to an IVF procedure. And that can typically vary anywhere from 10 to 15% per each IUI cycle or procedure. Next question. My husband suffers from infertility due to chemotherapy treatment 10 years ago. We are now beginning the IVF process. How can we be proactive before our first appointment, testing his frozen sperm through Boston IVF? Would that be an option? So that's a great question. I am glad that your husband has hopefully recovered from his previous treatment, and this is great that you guys and he has been proactive about freezing sperm before undergoing basically cancer treatment. You wouldn't necessarily have to do anything extra at this time. I would just prepare all your questions to meet with your fertility specialist, and then once you meet with them, they will discuss with you the process for having the vials of the frozen sperm transported over to our lab at Boston IVF. And basically, they will kind of go over and review the steps required prior to starting the process of IVF. Both you and your partner will need to undergo additional testing. The female partner will need to have blood work, ultrasound, anatomical, structural evaluation of the uterus, as well as the fallopian tubes. And then your partner will need to have some blood work done for genetic testing and infectious disease labs. And hopefully, once we have the vials of the sperm ready and available at our lab, we can then proceed with the IVF process, where our lab will be using his frozen sperm to fertilize and inseminate your eggs on the day of your egg extraction, your egg retrieval. And wishing you all the best. So the next question, hello, after how many cycles is good to take a break for the body? Thank you. Let me make sure I'm understanding this question. So after how many cycles of fertility treatment is it a good idea to take a break? So in general, when it comes to fertility and fertility treatment, we would like to proceed with back-to-back cycles or treatments as early as possible we possibly can. Meaning, if you are undergoing IUI treatments, we oftentimes proceed with treatments, the IUI cycles back to back every month. If you are proceeding with an IVF treatment, you'll undergo an IVF cycle, and let's say the cycle ends up not being successful, then typically there are going to be a few weeks where you are kind of resting and waiting for the next IVF cycle to start. And in general, you don't necessarily need to take a break after each cycle of IVF, after each egg retrieval procedure with IVF. Typically, after about 7 to 10 days, your body will go back to a normal non-hormonal state after starting a period, and then you can proceed with the next treatment, whether it's preparing for a frozen embryo transfer or another IVF cycle. However, if you have undergone many rounds of unsuccessful fertility treatments and you just emotionally are exhausted, physically are exhausted, and just need to take a break, there's nothing wrong with that. You can always take a few months, to regroup and take a break and recover from everything that you've been through and prepare your body to undergo future treatments. I hope this helps answer your question. The next question. What is your opinion about Omnitrope priming and Omnitrope and Metformin for stimulation? Are there any evidence for them? How can I advocate for and what to do if the doctor declines? That's a great question. So Omnitrope, which is human growth hormone, this is an injectable hormone that has been shown based on some studies and some data to help improve egg quality, oocyte quality, and embryo quality in women and individuals who are poor responders who have undergone previous failed IVF cycles. However, just like many other data information in our field, the studies are very mixed and overall not very conclusive. There are certainly studies that show benefits of using human growth hormone and Omnitrope, just like I said, in improving your egg quality, oocyte quality for people who are undergoing IVF, to help improve embryo quality and the end IVF outcomes, mainly for women who are poor responders and have previous failed IVF cycles. And there are certainly many studies out there that do not show necessarily a benefit. I would recommend discussing with your physician. Omnitrope is quite expensive. It is an additional injection that's oftentimes not covered by insurance, and you would have to pay extra for the vials of the human growth hormone. And I would discuss this with your physician. And if this is something that you would like to try and you haven't used before and you have done previous IVF cycles that have not been successful, I would certainly discuss about it with your physician to see if you would be a good candidate to use the human growth hormone as part of the IVF process. Metformin is an insulin sensitizing agent. Metformin is not a medication that is routinely used for controlled ovarian stimulation during the process of IVF. There are certain indications for prescribing metformin, including patients with PCOS who specifically have evidence of insulin resistance, high blood sugars, elevated blood glucose levels, as well as elevated blood insulin levels, and some PCOS patients with elevated androgens, or some with elevated BMI. There's some evidence that using metformin while going through an IVF cycle can help improve oocyte quality and IVF outcomes. Again, based on certain indications, and it's not something that we would prescribe for anyone. So again, this is a discussion that I will have with your physician based on your underlying diagnosis. I would have them check a hemoglobin A1C, which is a marker of your blood sugars, to determine if you would be a good candidate for prescribing metformin. The next question, 41 years old, no miscarriages, never been pregnant, no PCOS, AMH of 0.53. Partner sperm is good. We are trying and no results. How do I advocate for endometriosis to be tested for? First of all, at age 41, I assume that you've already started your journey by seeing a fertility specialist and having the testing not done. We know that unfortunately your AMH anti-Mullerian hormone level is low at 0.5, so slightly lower than average AMH that I would expect for your age at your age 41, which indicates slightly lower egg quantity. But in addition, your age, unfortunately, as you might know, can have a negative impact on the quality of your eggs and oocyte quality. If your main concern is, so I would definitely see a fertility specialist, have the all the testing evaluation done, which sounds like your partner has also had testing done, and discuss about your options moving forward with fertility treatment. Most likely, IVF would be one great option that you can consider, given the very low likelihood of success with IUI, and given how time is of the essence at your age. Now, if one of your main concerns is endometriosis, then you would have to again discuss about this with your physician. Some of the common signs and symptoms of endometriosis can include having chronic pelvic pain, severe menstrual cramping and pain during your periods, or pain during intercourse, pain at the time of having bowel movements, or just chronic pelvic pain in general. The diagnosis of endometriosis, however, is a surgical diagnosis. So if you truly want to be diagnosed and have a definitive answer and are very concerned about endometriosis, then you would have to go through surgery. You would have to have a laparoscopy done, which is basically inserting a camera through the belly button to look for endometriosis lesions, directly visualize these lesions and remove these lesions and send those lesions for pathological exam. If your end goal, however, is fertility, I may not necessarily waste time by having you go through surgery. I would just, consider proceeding with IVF directly, because just like I said, time is of the essence, and we don't really have a whole lot of data to suggest that surgery for endometriosis can help improve fertility for most women. So it's probably best to consider proceeding with IVF if there's a concern for having endometriosis. So let me make sure I'm getting a lot of questions, which is great. Thanks for sending your questions. So next question, we would like to start the injections in my next cycle. However, we're still waiting for the results of my partner's genetic testing, which we have been told should be available around the same time as I expect my period. So I was wondering Can I begin the injections before receiving the results, assuming they come out on the same day as my period? Alternatively, can I take birth control pills to delay my period slightly? If yes, when should I start them? For context, my last period started around April 11th, and I'm expecting my next cycle around May the 10th. My cycles are regular and usually last 5 days. Starting birth control pills can sometimes help with coordinating the timing of your IVF cycle start, especially if you are not quite ready to start right away. It's definitely something that I would discuss with your physician. You have to make sure that you are a good candidate for starting birth control pills for a few days to until the genetic test results are back. Typically, women who have diminished or very low ovarian reserve or certain population of patients were more hesitant to use birth control pills as those can sometimes have an oversuppressive impact on your ovaries. So it's something that I would discuss with your physician. Typically, the start timing for starting the birth control pills, that usually starts with the start of your first day of your period. The other option could be, just like you said, if they are pretty certain that your partner's test results are going to be available by the time you start the injections, the other option could be that you just start with the injections and proceed with with the IVF cycle as planned, and making sure the genetic test results are back and they are reviewed before you move forward with the egg retrieval. The main concern is that if you have been found to be a carrier for a certain genetic mutation and your partner is found to be the carrier of the exact same genetic mutation, that can put you guys at increased risk for having an affected child with the same genetic mutation, genetic disease. And this is something that we can prevent from by having your embryos tested by performing PGTM, which stands for pre-implantation genetic testing for monogenic disorders. But this is something that we need to know in advance so you can receive counseling about, and we can plan for performing PGTM on your embryos. So it's going to be very important to find out about your partner's test results before you proceed with extracting the eggs and creating embryos. The next question is, how quickly after the first consultation at Boston IVF can someone begin the egg freezing process if there are little to no infertility issues? Great question. Typically should be pretty quick. So typically you will have the first consultation visit with your reproductive specialist. We then will order some basic fertility testing, including checking your hormones and your egg quantity, including your AMH or anti-Müllerian hormone. After a few weeks, you will have another typically follow-up visit with your physician to go over those test results and go over realistic expectations about the process of egg freezing. We would then put together a treatment plan for the egg freezing process to be started, and it should take another couple of weeks before you're able to start. So from the time that you've seen your fertility specialist for an initial consultation, by the time you're able to start the actual IVF cycle, should take about 2 to 3 months. Just making sure that we obtain the financial clearance and you have all the injections, the medications, and ready to start. So the next question is that I've always wanted twins and triplets. Can I request to transfer 2 to 3 embryos at once instead of one when doing IVF procedure? So unfortunately not. The answer is no. So I just want you to know that human uterus, as I always like to say, has been created to carry one pregnancy at a time. Twin pregnancies and higher order multiples, including triplets and quadruplets, can be at increased risk, significantly increased risk. And these pregnancies oftentimes can become very complicated. These types of pregnancies can put you at increased risk for having OB complications, including preeclampsia, including IUGR or intrauterine growth restriction, preterm birth, premature babies, as well as can be harmful to the babies. There are some rare complications, including twin transfusion that oftentimes can require additional procedures for you to go through while being pregnant, which can become very stressful, just emotionally, physically, for you going through the process. So we highly advise and counsel against twins and higher order multiples. And at Boston IVF, we have very strict policies that would prevent us and individuals from having multiple embryos transferred, especially if the embryos have been tested. We know that we are transferring a genetically tested normal euploid embryo, and knowing that the likelihood of success with after putting back an embryo with IVF is pretty high, we try to minimize the risk for having future complications for you when you do become pregnant. So I highly would recommend against this and advise against this. And just like I said, we have strict policies in place that would prevent individuals and patients to undergo multiple embryo transfers at one time. So give each of your embryos a chance one at a time for a healthy, successful singleton pregnancy would be my advice. When is the protocol usually finalized and shared with me? So if I'm guessing correctly, you're talking about the IVF protocol, and this is something that you would oftentimes discuss with your physician at the time of your consult. Prior to IVF, they would kind of go over information about the medication regimen, the protocol, and then all the details will be formulated and drafted out and put together, and that protocol will then be sent over to the nursing team as well as the financial team to obtain financial clearance. And you can always reach out to your physician's team to ask about the details of the protocol. But at some point, definitely prior to starting the actual IVF cycle, the details of the injections, medications will be shared with you. But that information, I'm sure, can be accessed earlier than the time of starting the actual injections. So reach out to your team. The next question, how many tries of IVF does it usually take for a pregnancy to occur? That's a great question. That's a very individualized question that highly depends on your age at the time of doing IVF, as well as your underlying egg count, ovarian reserve. So if I'm seeing someone who is in their 40s, early 40s or late 30s, who has diminished ovarian reserve with a very low AMH level, I would counsel them that very likely they're going to require more than one IVF cycle to be able to bank good quality embryos and possibly achieve success. If I'm seeing someone who is in their 20s, early 30s, let's say someone who has PCOS with a very high AMH or normal egg reserve, the likelihood of success is usually going to be pretty high after one cycle of IVF. So it is going to be a very individualized question, also depending on many parameters, many fertility parameters, including your egg count, your ovarian reserve, as well as your egg quality, which is mainly determined by your age. So these are the two important factors that determine the success of an IVF cycle: your egg quantity, which is your AMH, as well as your egg quality, which is going to be mainly your age. The next great question. For an IVF treatment, does the sperm go through a washing process before the egg and sperm are joined, or is it case by case? It is going to be case by case, typically for depending on which technique we are using for fertilizing and inseminating the eggs. So sometimes this could be just a conventional insemination where the sperm and the eggs are placed together, put together in a dish in the lab, and we will allow for the sperm to find the eggs and fertilize the eggs or inseminate the eggs, just like this would happen inside of your body. And in certain cases, mainly in cases where there is male factor infertility or poor sperm parameters, ICSI technique or intracytoplasmic sperm injection technique will be used, where the sperm is going to be selected. So the best quality sperm is going to be selected, and those sperm are going to be directly injected or inserted into the eggs in hopes of improving fertilization and maximizing fertilization of the eggs with the sperm. Another great question. What if you have two children that were born normal without fertility issues? Is it better to try IUI or IVF if we are not able to get pregnant naturally a third time? So that's a great question. And unfortunately, having had previous children may not necessarily determine your success with IUI or IVF. Those success rates are going to stay the same. So success rates are almost always higher with IVF, about 4 to 5 times higher, depending on your age and your egg counts or egg quantity. It's going to be as high as 60 to 62% for IVF, as opposed to lower success with IUI. And this is really independent of secondary or primary infertility. Unfortunately, there are many cases of secondary infertility where individuals have had no problems conceiving in the past and have been able to conceive without any assistance, who might end up needing to have assistance and IVF or other types of treatments done in order to conceive. So can't really answer that question because those success rates are still going to stay the same. So even if you have had previous children, the IUI success rate is going to be lower at about 10 to 15% per IUI cycle, and it's going to be higher success for IVF, especially if you are older or have issues with lower egg count, egg reserve. Next question. How does being treated with methotrexate for a suspected ectopic pregnancy, which was actually an intrauterine, affect future transfers and future chances of success? So in general, should not impact your future transfers or future chance of success. If this was a truly an ectopic pregnancy, let's say pregnancy inside of the tube, then IVF will probably be a better option for you, knowing that there could be very likely, some degree of tubal disease. But based on what you're saying, this was an actual intrauterine pregnancy, but your physician likely prescribed methotrexate because of abnormally rising HCGs or because they could not confirm that this was an intrauterine pregnancy. But typically, we recommend not trying to conceive or get pregnant after 3 months of being administered methotrexate. But then after that, you can proceed as normal, and that should not have it. The medication will not stay in your system. So it's not going to have a negative impact on any future pregnancies or your future chances for success. Next question. Thank you so much for answering my question about the possible endometriosis at age 41. HyCoSy and Hysteroscopy, all good. Nothing was found. I will not waste my time asking if I have endometriosis since I don't have any pelvic pain during menstruation or intercourse. I will focus on IVF. You're very welcome. Also, just please note that having a normal HyCoSy, which indicates a normal evaluation of the cavity of the uterus and your fallopian tubes, as well as a hysteroscopy, which is an evaluation of inside of the cavity of the uterus. Those again necessarily will not necessarily rule out endometriosis because for the diagnosis of endometriosis, you will really need a laparoscopy to look inside the pelvic and abdominal cavities. A hysteroscopy will only look inside, and we will visualize inside of the cavity of the uterus. Having said that, just like you said, if you don't have any other symptoms of endometriosis, if your ultrasound evaluations have been normal with nothing concerning for a possible endometriosis cyst on your ovaries, just like you said, I think I would just focus on starting the process for fertility treatment sooner than later because time is of the essence. Next question. What would you recommend someone to do in the weeks and months leading up to their first IVF cycle to best prepare for the body? Is acupuncture helpful to start early? And if so, what would be a good frequency? That is a great question, actually. That's something that I always talk to my patients about, how they can prepare themselves and their bodies prior to starting the process of IVF. And I always like to say to try to include healthy lifestyle modifications and dietary modifications, trying to live your best, healthiest version of yourself, really focusing on diet and dietary changes. And the diet that has been mostly recommended for individuals who are trying to conceive and undergo fertility treatments will include a Mediterranean diet, which really focuses on a lot of fresh plant-based products and fresh, healthy fruits and vegetables, and minimizing really processed foods and processed carbohydrates, and really focusing on healthy sources of fat and complex carbs, as well as regular daily exercise, even if it's walking for half an hour every day. Avoiding any chemicals or toxin exposure. So don't smoke, don't smoke any nicotine cigarettes, no marijuana smoking, really avoiding anything that could have a toxic effect on your eggs, and for your partner, if applicable, anything that could potentially harm the quality and the health of the sperm. And then minimizing alcohol, really 1 to 2 alcoholic drinks per week would be the most that I would recommend while you're preparing your body for the process of IVF, as well as minimizing caffeine. You can still drink caffeine. Typically, up to 250 milligrams of caffeine is fine to administer and to use when you are trying to conceive or preparing to undergo IVF or other fertility treatments. And you mentioned about acupuncture. That can also be a good thing to try. Just like I have said previously, there are mixed data about acupuncture. Some studies that have shown that acupuncture can be beneficial, and some studies do not necessarily report any major benefits to doing acupuncture. If this is something that you're interested in trying, you can certainly look into that and try maybe for a session or two. If it's something that is helping you relax and making you feel physically and emotionally, mentally better and more prepared, I would definitely keep trying it. But if it becomes a hassle, if it's something that is not covered by insurance, if you have to take time off work and it becomes an extra stress for you, you don't necessarily have to worry about it. And in our Waltham Center, actually, we do have at our Boston IVF Waltham office, we do have a wellness center, and you can reach out to them. And we have people who are there and offer acupuncture treatments for our patients. The next question, I am 30 years old with PCOS. Is it better to bank enough embryos for 2 kids or move ahead with a transfer if I get 2 PGTA tested embryos? That's a great question. Typically, when you do IVF with PGTA testing or IVF for embryo banking, because the likelihood of success per embryo transfer on average is about 60 to 62%. Again, depending on the quality, the grading of your embryos, and the day of the development of your embryos, whether it's a day 5 or a day 6 or a day 7 embryo. Typically, my recommendation is to try to bank 2 to 3 embryos per desired pregnancy. So if you end up with 2 PGTA tested embryos and you ideally would like to have 2 children, I would highly recommend and consider proceeding with another IVF cycle before having an embryo transfer to be able to bank more embryos. So 2 to 3 frozen embryos per desired pregnancy, and knowing that you may not always be successful after having a frozen embryo transfer done. Even after transferring a completely genetic euploid embryo, there's always about 40% likelihood that the embryo transfer might fail, unfortunately, just because IVF is not a perfect science. What is the cost difference from IVF and IUI? So the cost difference can be significant. We are very fortunate that here in the state of Massachusetts, most insurances, if you are using insurance coverage, cover the cost for IVF and IUI. So typically it's going to be a few $1,000s for an IUI procedure if you are paying out of pocket, as opposed to it can be as high as $20,000 to $25,000 if you are planning for IVF, also depending on if you are planning on doing genetic testing or PGT testing of the embryos. Next question, just making sure that I'm getting to all of these questions. If all of my embryos are AA or AB quality, would they likely be normal embryos, or is there a chance some could be abnormal? For context, they were frozen in late 20s, and I'm currently in early 30s with one already successful fresh IVF transfer, currently about to start my first frozen cycle. So wondering likelihood of success with a frozen transfer now and normality of the frozen embryos we have. So this is great that you have done IVF before at, your young age of when you were in your 20s. And I'm really hoping that you are able to use these previously frozen embryos. Sounds like they have great quality or great grading based on the grading of AA and AB. But unfortunately, the morphological grading of the embryo does not necessarily correlate with the genetics of the embryos, meaning there are still many beautiful looking, morphologically great looking embryos that could still be genetically abnormal or aneuploid. I would say that based on your age in your 20s when these embryos frozen, the likelihood for having age-related aneuploidies in your 20s is going to be pretty low. So I'm hoping that these embryos are mostly genetically normal. But again, cannot necessarily say for sure that all of the embryos that you have frozen previously are going to be genetically normal. There could still be some aneuploidy within these embryos that unfortunately we can't tell unless we do the genetic testing of these embryos, meaning unless these embryos are thawed and you put them through additional genetic testing and refreeze the embryos, or to just proceed with the transfer and keep transferring embryos until you are successfully pregnant. So good luck to you. For the next question, for the egg retrieval procedure, how many hours in advance can my partner drop off the sample? If they drop it off at 4 hours in advance, will it stay good? Typically, our recommendation is within an hour or two, because if we're using fresh sperm, yes, we don't want the sperm to sit there for a very long period of time. So within an hour would be when your partner is going to be scheduled to have the sperm collection or the semen collection done to drop it off prior to your procedure. We need to have sperm readily available for right after when your eggs are extracted. But we don't also want to wait for 4 hours as that can impact the quality of the sperm. Just making sure that we have time to go through more questions. So all of my tests have come back clear. My husband has low morphology. All his other counts were great. Would IUI or IVF be better for us? We are currently trying letrozole. So that's a great question. Low sperm morphology by itself may not necessarily be a predictor of success for IUI. And depending on how low the morphology is, sometimes you could still try a few cycles of IUI. I've certainly had several people who have had male factor infertility with low sperm morphology, great sperm concentration and counts, and they were still able to succeed with an IUI procedure. So if that's something that you have decided and have started, I would proceed with a few cycles of IUI. But again, this also depends on some of the other parameters, how low the morphology of the sperm is, and your test results. And then I would really try to limit the IUI procedure cycles to 3 to 4 rounds of IUI, because really, based on most data, most pregnancies occur within the first few cycles of IUI. So if you have not been successful after 3 to 4 cycles, I would highly recommend proceeding with IVF and not wasting more time. Good luck to you. How frequently do you need to visit your doctor during the 2-week stimulation shots? Actually, most patients or most of us do not necessarily visit our patients while you're going through the IVF process procedure. So basically during this time, you are using the hormonal shots, injectable hormones on a daily basis. Every few days, you're coming into one of our offices for monitoring visits. And these visits involve having a transvaginal ultrasound, oftentimes an ultrasound of the ovaries, as well as some blood work to check your hormones to assess your response to the medications. Your physicians basically will obtain these results. So these results will be sent over to us, and we're here behind the scenes and basically reviewing all of those results. And based on those results, your physician will then do dose adjustments as needed. So they will tell you how soon they would like to see you back again, how many more days of the injections you have to use, and if there are any dose adjustments or modifications that have to be made, your physician will determine that, and oftentimes this will be communicated to you through the nurses. You may not necessarily have to see your physician for those test results, as we are continuously monitoring everything here behind the scenes. Another question. How far are the bookings to make an appointment with you? Most of the doctors at Boston IVF booking in July. Well, thank you for reaching out. I myself, including all of my partners, we're always happy to see you. I think it all depends on how busy we are, but just like you said, I think most of us are booking at least a month or two in advance for a new patient visit. So I would reach out to the office, to the new patient scheduling, and have them check my schedule or any of my other partners. We're all here for you, happy to see you, and hopefully you can book that initial consultation. The other question, I had an unsuccessful frozen embryo transfer with a 5AA PGT tested embryo. I believe it implanted, then stopped progressing due to faint lines on a home pregnancy test. No known issues except blocked tubes and small amount of scarring in the uterus, but have had previously hysteroscopy to clear. What do you think? Why do you think it didn't work? Well, I'm so sorry it did not work, and that is a great question. And unfortunately, that's a loaded question. So, for the success of an embryo transfer, there are really two main components. So, there's the embryo, and we need a good quality PGT tested euploid embryo, which you clearly have had a 5AA. That's great quality morphologically, great embryo that was PGT euploid embryo and tested. And then we also need a healthy uterus and a healthy uterine environment. And sounds like your uterus, you've had testing done before and you had some scarring, but sounds like you had the lysis of adhesions done, and that was taken care of. However, there are many, many, many other factors, unfortunately, at a cellular, molecular level, including immunological factors, autoimmune related factors, many other factors that we simply are not aware of or don't know about, and our science and technology is not advanced to be able to determine and identify those factors. Many things have to happen, have to come together at a cellular, molecular level for an embryo to be able to implant and successfully stick to the lining of the uterus and be able to further grow and progress and develop. And we simply don't know the answer to many of those other factors, unfortunately. Plus, we do know that even a perfectly great looking, beautiful looking, morphologically normal looking embryo that has been tested euploid may still not have the potential to develop into a successful pregnancy and a healthy individual. And unfortunately, there are many, many unknowns. At some point, we're hoping that with all the advances in research and in science, we can have more answers. But in this case, we simply may not know, may never know. And so I would recommend, if you hopefully have some additional embryos to transfer, I would recommend proceeding with the next transfer and knowing that hopefully there's going to be a high likelihood of success in the end after transferring 2 to 3 genetically tested normal embryos. All right, just a few more minutes left, so I'll probably get to one more question. Hi, for the IUI, how do they determine to go with medication or bio-natural cycle? I'm getting ready for this step, but have one tube that is blocked from a previous ectopic pregnancy. So it depends on your so sounds like tubal factor in your case. And as long as all your other test results are normal, and as long as you are regularly ovulating, having regular menstrual cycles, your physician may decide to have you try a few natural cycles without any intervention. And then if there's concern for poor response, or if your body is not able, your ovaries are not able to grow an egg or a mature follicle, then in those cases, or after a few unsuccessful natural cycles, your physician might decide to use an oral fertility medication to help boost and strengthen your ovulation. Oftentimes, we use the oral medications for women with PCOS who have issues with not being able to ovulate on their own. Or sometimes in the setting of having unexplained infertility. In your case, again, as long as all your other test results are normal and you are having regular menstrual cycles and regular ovulation, you might want to try a few natural cycles and monitor the natural growth and development of an ovarian follicle before adding an oral medication. And let's see, maybe one more. How frequently are the doctor visits for an IUI cycle for someone with PCOS. So again, for the IUI procedures, because we are a very big practice, thankfully, very high volume and successful practice, your IUI procedures are oftentimes done by one of our wonderful MAs, medical assistants, who are fully trained in performing these types of procedures. So you may not necessarily see your physician for an IUI procedure at our practice, or sometimes in more complicated cases, a nurse practitioner or one of the physicians might need to intervene. But in general, IUI procedures are not being performed by the physicians. But we do see you regularly to follow up on test results after a few failed IUI cycles if you're ready to discuss proceeding with IVF. Thank you, Dr. Arian. This was so helpful, and you're very welcome. Thank you for joining me tonight. I think we are done with all the most of the questions, and I'm sorry if I didn't get to any additional questions. And thank you so much for joining me.